Hello everyone. In this lecture, we're going to study about some of the disorders involving the thymus. First, we'll start with the developmental disorders, and the first entity is chromosome 22q 11.2 deletion syndrome. Okay, chromosome 22q 11.2 deletion syndrome. As you all know, as we have discussed in the basics of thymus, the thymus has dual origin. The endodermal component comes from the pharyngeal pouches, predominantly from the third pharyngeal pouch, uncommonly from the fourth pharyngeal pouch. And the mesoderm component comes from the bone marrow, basically the developing T lymphocytes, which are otherwise known as the thymocytes. They come from the bone marrow, so that is why they have the mesodermal origin. Okay. So what happens in this condition, this chromosome 22q deletion syndrome? What is going to happen in this condition? So basically, in this condition, this chromosome 22q 11.2 region is deleted. This region actually it's a large area, large region, around 1.5 MB, which contains around 30 to 40 genes. 30 to 40 genes. Depending on which genes are predominantly affected, it can produce two separate syndromes. The first one is Digeorge syndrome. Digeorge syndrome. And the second one is velocardiofacial syndrome. Velocardiofacial syndrome. What happens in Digeorge syndrome? In Digeorge syndrome, the thymus and the parathyroid gland both are underdeveloped. Okay, so either they are absent or they are underdeveloped. As we have discussed previously, the third and fourth pharyngeal pouch, both of them will give rise to parathyroid gland. Basically, the third pharyngeal pouch will give rise to the inferior parathyroid gland, and the fourth pharyngeal pouch will give rise to the superior parathyroid gland. And I have already told you that third and fourth pharyngeal pouch will also give rise to thymus. So basically, there is a defect in the pharyngeal pouches, the third and fourth pharyngeal pouches. So that is why in this condition, there will be defective or underdeveloped thymus and the parathyroid gland. Defect in the thymus will cause absence of T lymphocytes, absence of T lymphocytes. So if there is absence of T lymphocytes, there will be defective cell-mediated immunity. Okay, so T lymphocytes, they play a role in cell-mediated immunity. B lymphocytes, they play a role in humoral immunity. If the patient doesn't have T lymphocytes, there will be defective cell-mediated immunity. Okay, so basically the patient will have immunodeficiency and they are prone for infections. And also we have discussed, in this condition, if you take the cross section or the section of a lymph node, you are not going to find, you are going to find an underdeveloped paracortex area. Okay, because the T lymphocytes, they are normally present in the paracortex of the lymph node. And in this condition where the T lymphocytes are absent, the paracortex of the lymph node is going to be underdeveloped. Similarly, if you take the section of a spleen, we are not going to find the periarteriolar lymphoid sheath, which is made up of T lymphocytes. And if the patient doesn't have parathyroid gland or it's an underdeveloped parathyroid gland, there will be reduction in parathyroid hormone levels. That is going to cause hypocalcemia. Okay. Along with this, like any other immunodeficiency conditions, all those things we'll discuss under immunology section. These patients are also associated with autoimmune disorders and atopic conditions. Okay. But what happens in velocardiofacial syndrome? Here, the patient is going to have various facial abnormalities and cardiovascular abnormalities. So facial abnormalities, it includes prominent nose, retrognathia. Retrognathia means the mandible gland will go backwards. Okay. Prominent nose, retrognathia, then cleft palate and other palatal abnormalities. All these things, all these facial abnormalities we are going to find in this condition. Apart from this, these patients are going to have various cardiovascular abnormalities, especially the cardiac structural abnormalities. Okay, so these are the two syndromes that can happen because of this chromosome 22q 11.2 deletion syndrome. Because this region is containing 30 to 40 genes, and depending on which genes are predominantly affected, they are going to cause these two syndromes. Okay. But you need to understand one thing. It was old concept. I mean, previously it was believed that these are two different syndromes. But with current understanding, now we know that these are actually two entities of the same spectrum. That means if the patient has Digeorge syndrome, they will also have some features of velocardiofacial syndrome. And if the patient has predominant features of velocardiofacial syndrome, they will also have, they will also have mild features of Digeorge syndrome. Okay, so there is considerable overlap between these two entities. So that is why now we believe that these are two entities of the same spectrum. Okay, along with these clinical features, these patients are also going to have various psychiatric abnormalities, which include attention deficit hyperactivity disorder and also schizophrenia. These patients are prone to develop attention deficit hyperactivity disorder and schizophrenia. Okay. One more point you have to remember is these syndromes can also be found due to mutation, due to deletion in 10p, 13, 14 region. Okay. So deletion of 10p, 13, 14 region can also cause this syndrome in rare cases. Okay. Now we'll understand what is the molecular basis. Okay. So now we'll understand what is the molecular basis behind these features. So what is the gene involved for this Digeorge syndrome? As I have told you, there are around 30 to 40 genes that are involved. However, we are going to focus on one gene which is very important. That is known as the TBX1 gene. TBX1 means T box 1 gene or Tata box 1 gene. T box 1 gene. Actually, this is a transcription factor. This is a transcription factor which is going to act upon another gene which is present on chromosome 14, and the name of that gene is PAX9. PAX9. Okay, so out of those 30 to 40 genes, one of the very important genes is TBX1, which is Tata box 1 transcription factor. This is transcription factor for another gene which is named as PAX9. This PAX9 is present in chromosome 14. Okay, and these genes are expressed in pharyngeal mesenchyme. These are expressed in pharyngeal mesenchyme and endodermal pouches. The pharyngeal pouches, endodermal pharyngeal pouches. Okay, so basically these genes are expressed in pharyngeal mesenchyme and endodermal pharyngeal pouches. And if there is defect in these genes, there will be defective pharyngeal mesenchyme formation and defective pharyngeal pouch formation. So that is going to cause various facial and the thymus parathyroid gland abnormalities. Okay, so this gene is very important to remember. That is TBX1 gene, which is a transcription factor for PAX9. How we are going to diagnose this condition? How we are going to diagnose this Digeorge syndrome? So the diagnosis is made by FIS, that is fluorescent in situ hybridization. Fluorescent in situ hybridization. Remember, we're going to discuss this a little bit in more details when we will under the section of genetics. Okay. Now I'll just tell a very few points to understand the basics. So what we do in fluorescent in situ hybridization, basically we culture the chromosomes. As you can see, this is actually interphage. These are metaphase chromosomes. Okay. And now we are applying some probes which are fluorescent in nature. Okay, so we are applying some probes. We are applying two types of probe. One is the yellow probe, another one is one is the green probe, another one is the red probe. Okay, so green probe is actually it is going to identify the chromosome 22q region, which is a control probe, and the red probe is it will go and bind to the exact area of interest, that is the chromosome 22q11.2 region. Okay, so red probe is going to get attached to this region. If you focus here, if you see the metaphase chromosomes, you can identify two chromosomes. So basically, this is a normal chromosome 22 because it is binding both the green probe and the red probe. That means it has chromosome 22q area. I mean, it has the chromosome 22q and also it has the chromosome 22q11.2 region. So that is why it is binding to both green probe and red probe. Okay, but if you see the another chromosome 22, this one, I mean, you all must be knowing that all the chromosomes are present in pair. That means chromosome 22 in chromosome, I mean, you will have two chromosome 22, one from the father, one from the mother. So this is actually normal. But if you see here, this chromosome 22, you can appreciate that it has 22q, but it doesn't have the area of interest, that is 22q11.2 region. Why? Because it is not binding to the red probe. Okay, so that means this patient is having deletion of this chromosome 22q11.2 region. Okay, so this is how we diagnose Digeorge syndrome with the help of FIS. Okay, so this is about the Digeorge syndrome or the chromosome 22q11.2 deletion syndrome. Now we'll come to the second entity, that is thymic cyst. So what do you mean by cyst? Cysts are nothing but fluid filled spaces which are covered by some kind of epithelial lining. Usually the thymic cysts, they are very small in nature. Rarely they exceed more than 4 centimeters. 4 centimeters. That means most of the thymic cysts are less than 4 centimeters. Because of their small nature, they are not going to produce, isolated thymic cysts, they are not going to produce any symptoms. Usually they do not produce any symptoms. Only they are incidentally diagnosed. Most of the times they are incidentally diagnosed in the post-mortem examination. Okay. Most of the times they're incidentally diagnosed in the post-mortem examination because they are very small in nature. They are not going to produce any symptoms. These are usually lined by, as I told you, they will have some kind of epithelial lining. These are usually lined by stratified or columnar epithelium. Stratified or columnar epithelium. The fluid is, it can be serous or it can be mucinous. And many times it may be associated with some kind of hemorrhagic fluid. Okay. But if the patient has symptoms due to thymic cyst, this is actually an alarming condition because, as I told you, isolated thymic cyst, they are not going to cause any symptoms. But if the patient is symptomatic because of thymic cyst, you have to carefully look for some kind of malignancy in the thymus. Okay. If the patient is symptomatic, look for malignancy, because various malignancies of thymus, it is going to compress the adjacent normal parenchyma and cause production of the cyst. Okay, so malignancies like lymphomas infiltrating thymus, we have to look for those malignancies. Okay, because many times these malignancies, they are going to compress the normal thymus parenchyma and cause formation of the cyst. And those cysts, because of the mass lesion and along with the cyst, they can be symptomatic. However, isolated thymic cysts are not symptomatic. Okay. So these are about the developmental disorders. Now we'll discuss some other entities. The next one is thymic hyperplasia. So basically, thymic hyperplasia means it refers to thymic follicular hyperplasia. Follicular means we are referring to the B lymphocyte follicles. You must be remembering that the normal thymus doesn't contain B lymphocyte follicles. Okay, so B cell follicles are found in the spleen and lymph nodes. These are not found in thymus, or even if they are found, they are very less in number, very less in number. Usually, you are not going to find the B lymphoid follicles, but there are certain conditions where you are going to get this B lymphoid follicles. Okay, and usually these are associated with myasthenia gravis, Usually this thymic follicular hyperplasia, it is associated with myasthenia gravis. Around 60 to 70% of the patients with myasthenia gravis, they are going to have this B lymphoid follicles. Okay. Also, there are certain other conditions which are associated with this follicular hyperplasia, and those conditions, I mean, these are actually immune-mediated conditions like rheumatoid arthritis, SLE, systemic sclerosis, and Graves' disease. Sorry for the interruptions because of some technical issues. Graves' disease. Okay. So various immunological conditions, autoimmune conditions, connective tissue disorders, these are going to be associated with thymic follicular hyperplasia. But the most important cause that we have to remember is myasthenia gravis. Around 60 to 70% of patients with myasthenia gravis, they are going to have thymic hyperplasia. Now coming to the last entity, thymoma. So basically, thymoma means it is a tumor of thymic epithelial cells. Okay, so it's very important point to remember because many times we do mistake that thymoma is a tumor of thymocytes. No, thymoma is not a tumor of thymocytes. It is a tumor of thymic epithelial cells. It doesn't happen in children. The age group is more than 40 years of age. It happens in more than 40 years of age. Equally distributed in males and females. Equally distributed in males and females. And usually they are located in anterior, superior mediastinum, anterior, superior mediastinum, because that is the normal location of thymus. That is the normal location of thymus. So thymomas are usually located in anterior, superior mediastinum. And whenever you find a anterior, superior mediastinum mass, the close differential, I mean, thymoma is one of the differential, but the another close differential is lymphoma. Okay, so whenever you find anterior, superior mediastinal mass, the two important differential diagnosis that you're going to have is thymoma and lymphoma. Okay, though it is the most common location, this is the most common location. Sometimes thymomas can also be found in the neck, in the thyroid region, and pulmonary hilus region. Pulmonary hilus region. Okay, so these are some of the rare sites where you can find thymomas. Okay, grossly, these are, these are lobulated. Gray lobulated masses. And usually these are 15 to 30 centimeter in diameter, 15 to 30 centimeters in diameter. And rarely, they may have cystic necrosis and hemorrhage. These are plus minus findings. Usually these are not found, but sometimes they can also have cystic necrosis and hemorrhage. Okay. Anyway, these are not very important points. Now we'll discuss the really important points about the thymomas, that is the histologic subtypes. So basically there are three important subtypes that you have to remember. The first one is cytologically benign and non-invasive. Second one is cytologically benign and invasive, and third one is thymic carcinoma. So let us discuss about the cytologically benign and non-invasive variety, and this is the most common type of thymoma. Around 50% of the thymomas are benign and non-invasive. These thymomas, they are predominantly originating from the medullary thymic epithelial cells. Okay, they predominantly originate from the medullary thymic epithelial cells, but sometimes they can originate from the combination of medullary and cortical thymic epithelial cells. Okay, so the point you have to understand is the more medullary epithelial cell component you have, the more benign is the disease. Okay, and of course, if it is originating from the medullary region, the thymocyte number is going to be less in this condition. Okay, so if you see, this is actually thymoma, which is cytologically benign and non-invasive. You can appreciate the medullary thymic epithelial cells. How you can find, how will you differentiate between a medullary and cortical thymic epithelial cell? Those points we have already discussed in the basics of thymus. Okay. So medullary thymic epithelial cells, they will have lesser cytoplasm. Actually, they are spindle shaped. They will not have dendrites. They will have lesser cytoplasm. Okay. And in this region, we are going to find very less thymocytes. Okay. So basically, the dark staining cells, these are actually thymocytes. Okay. And these are very less in number. And the other cells are spindle shaped. Others are spindle shaped medullary thymic epithelial cells. Okay. So these are the points about cytologically benign and non-invasive thymomas. The second one is cytologically benign, but these are invasive. And around 20 to 30% of the thymomas fall into this category. And here it originates from the cortical thymic epithelial cells. Okay, because they are originating from the cortical thymic epithelial cells, these are invasive. And of course, in the cortex, we are going to find more thymocytes. And the reason behind this, we have already discussed in the previous lecture. Okay, so in the cortex, we are going to find more thymocytes. I mean, thymocytes are the developing T lymphocytes. So if you see the section, you can find these are the tumor cells. These are the cortical thymic epithelial cells, which are polygonal cells. These are polygonal. And they will have abundant cytoplasm. These are polygonal cells and they will have abundant cytoplasm. Okay. And you can appreciate that these dark staining cells, these are all thymocytes. These are all thymocytes. So basically, in this condition, you're going to find polygonal cells and thymocytes. Of course, these are invasive, so you are going to find capsular invasion. Capsular invasion. Okay. So these are the important points about the benign non-invasive thymoma and benign invasive thymoma. So benign non-invasive thymoma is the most common type. 50% of the thymomas originate predominantly from the medullary thymic epithelial cells. Thymocyte numbers will be less. And these cells, these are spindle shaped cells, and they will have less cytoplasm. However, the benign and invasive variety, it originates from the cortical thymic epithelial cells. That is why the cells are polygonal. They will have more cytoplasm. The number of thymocytes will be more, and in this condition, we are going to find capsular invasion. And 20 to 30% of the thymomas fall into this category. Coming to the last entity and the most severe entity, that is the thymic carcinoma. Only 5% of the cases are, only 5% of the thymomas are actually thymic carcinomas. And the most common subtype is squamous cell carcinoma. That is the most common subtype. But there is a very unique variant that is known as lymphoepithelioma. Lymphoepithelioma-like carcinoma. Lymphoepithelioma-like carcinoma variant. Okay, so this is a very unique variant. This lymphoepithelioma-like variant, this mimics nasopharyngeal carcinoma. This mimics nasopharyngeal carcinoma, and around 50% of the cases, around 50% of these cases are associated with Epstein-Barr virus. Okay, so the morphology of this variant will be very much similar to the nasopharyngeal carcinoma. Okay, nasopharyngeal carcinoma we'll discuss under the head and neck section, and around 50% of these cases of lymphoepithelioma variant is going to be associated with Epstein-Barr virus. Okay, so this is about the histological subtypes. Now, what are the clinical features? Now, this is very easy to understand. Now, thymomas, they are present in the anterior superior mediastinum. So most of these cases, they will have some kind of mass. I mean, they're going to have some kind of compression features. Okay, so they're going to have some kind of compressive features. That means they're going to compress the other mediastinal structures. If they compress esophagus, they're going to have, the patient is going to have dysphagia. If it compresses the trachea, patient is going to have dyspnea, that means shortness of breath. And if the patient, if it compresses the superior vena cava, it is going to cause superior vena cava syndrome. Okay, so superior vena cava syndrome means because basically the venous drainage from the face is affected, so that is why there will be facial swelling, facial puffiness, and all those things are going to happen. Okay, so around 40% or the most common symptom is compression of the mediastinal structures. Okay, but around 30 to 40% of these cases are diagnosed during the evaluation of myasthenia gravis. Okay, so this point is very important to remember. As I have told you previously, myasthenia gravis is associated with thymic hyperplasia, but you need to understand that myasthenia gravis is also sometimes associated with thymomas. Okay, and around 30 to 40% of the thymomas are diagnosed for the first time during the evaluation of myasthenia gravis. This can also be associated with various other autoimmune disorders like it can also be associated with dermatomyositis, polymyositis. These are all inflammatory myopathies. We will discuss these things under the section of peripheral, under the section of skeletal muscles. So they can be associated with dermatomyositis, polymyositis, pernicious anemia, which we have already discussed under the anemia section, under the megaloblastic anemia section. Okay, and these are also going to be associated with PRCA, Graves' disease, and hypogammaglobulinemia. Okay, so PRC, pure red cell aplasia, Graves' disease we'll discuss under the thyroid pathology section, and also hypogammaglobulinemia. Hypogammaglobulinemia. Okay. So these are some of the other autoimmune conditions that are associated with thymomas. The last point you have to remember is most of these autoimmune manifestations are associated with cortical thymomas. Okay, so cortical thymomas, they are associated with generating autoreactive T cells, and these things are going to they are going to cause the autoimmune manifestations. Okay, so these are all the important points about thymomas, and that's all about the thymic pathology.